First thing to say is the most important thing in lupus nephritis is who's looking after you and where are you being looked after. So this is a very recent study from the States, and it looked at the frequency of death and end-stage renal disease in lupus nephritis patients cared for under Medicaid, i.e. poor people, limited access to healthcare, or patients attending the SLIC clinics. And the SLIC is like the elite lupus research clinics. And you can see that at 5 years there was almost a 10% mortality, 22% on end-stage renal disease. This is in the USA, a rich society. But the patients presented the SLIC clinic at 10 years, it was 5.9% and 10.9% ESRD. So almost 3 or 4 times better. Similar types of patients, just where are they pitching up? And I think that sort of pervades the lupus field. So, my complaint about histologic classification is it's predominantly done by pathologists for pathologists and not for us, not for nephrologists. What the pathologists have been trying to do is to understand the pathology, understand the mechanism of what's going on. That lay behind their approach to classification, but it hasn't really been very useful to you and me. The patient's got active lupus nephritis, proliferative so-called lupus nephritis, we treat them and we don't take a whole lot more notice within reason of the renal biopsy. It is not outcome-based, so unlike the Oxford IgA system, where it's based on outcome, the lupus nephritis system has never been linked in a prospective way to outcome. And it doesn't integrate with other important aspects of the disease, such as serology. Anyway, the original system, designed on a postcard outside a cafe in Paris by 2 pathologists attending a meeting, and that postcard has been photographed many times, was updated in 2003. But this was really a tweak. It wasn't a major revolution. And the systems really remained the same, but some of the differences were if you had both proliferative changes and membranous changes, then you called it a 3+5 or a 4+5 rather than the previous terminology. And the category 4 was divided into global or segmental subtypes, of which I'll say a bit more. But the activity or the chronicity was not standardized. It just referred to the usefulness of using an activity or chronicity score. And this system ignores the tubular interstitium, the blood vessels, thrombotic lesions, and the podocytes. And we know that all of these components have independent predictive value, particularly recent interest about podocyte survival and podocyte death in terms of renal outcome. So there's now an effort to change it again. But don't worry, it's not going to happen quickly. So what happened is the Renal Pathology Society got together and started an initiative to talk about lupus nephritis biopsies. And what they realized was the standardization in how biopsies were assessed was enormously variable. And what one pathologist called proliferative, another pathologist didn't call proliferative. What is proliferation? What is endocapillary proliferation? Is it white blood cells? Is it the number of white blood cell nuclei? Is it something else? And this paper that was published in KI about a year or 2 ago was really a lot of work to standardize the terminology. So this is not a new classification, but this is a building block towards a new classification. It's trying to get the pathologists talking the same language. Nephrologists have not been involved in this, as all pathologists, but if they get their act together, then the next step will be to try to develop an outcome-based classification like the IgA, but we're nowhere near there yet. Just to give you an example, I mentioned that class 4 was divided into this global, with segmental or global, so this is an example of a segmental lesion where the rest of the glomerular tuft is fairly normal, as opposed to a diffusely abnormal glomerular tuft where there's widespread immune complex deposition. Now, preliminary data suggested that the prognosis of these lesions was very different. So what happens? These are all the studies that have compared G to S, and there's no difference at all. Why is that? It's partly because the pathologists are not standardizing what they're calling segmental or global. How big does a segment have to be a segment? 25%, 50%, 70%? It's not quite clear. So I don't think this is borne the test of time. As far as the tubular interstitium is concerned, the one thing that I look at in a biopsy of a patient with lupus nephritis is the tubular interstitial scarring, the IFTA, because that to me is the most important prognostic value. If there's extensive glomerular disease, I don't mind too much, but if there's extensive tubular interstitial disease, I know that patient will go on to chronic kidney disease and may well go on to dialysis, whatever I do. And this has been borne out by other studies. Look at the various parameters of damage in the damage score. It's the tubular interstitial damage that correlates most closely with ESRD risk. And this is sort of a reason why. This is work done by Marcus Clark's group in Chicago, where he's looked at the tubular interstitium, and he's basically made the case that there's a different pathology going on in the tubular interstitium. You see T cells there, you see B cells, you don't usually see T and B cells in the glomerulus. And these are forming lymphoid follicle type structures with stromal cells. And he's looked at the autoantibodies being produced by these lesions, and they're not lupus antibodies, they're anti-renal antibodies. So he estimates that about a third of patients have these lesions, and these he thinks are what's driving some of this tubular interstitial scarring. And maybe the target for a different sort of treatment where these are present. At the moment, not. So this is easy. When should you consider lupus nephritis as a nephrology audience? We know that, it's the whole time. But this is for a rheumatology audience. It's any sign of renal involvement. We want the patients before their GFR has started to decline. So any sign of renal involvement, and renal biopsy recommendations are proteinuria that's persistently above an ACR of 0.5 or 50, especially this hematuria. But what you have to remember is that if you've got a patient with persistent white cells in the urine with no protein, or persistent red cells and no protein, around 2/3 will have nephritis on biopsy. So proteinuria is not an absolute. And there are a few, especially those with more thrombotic disease, antiphospholipid syndrome type disease, that will have a reduced GFR with a completely bland urine, and that can be a challenge. So what are the themes about treatment? And this is what you wrestle with and what I wrestle with. So you've got cyclophosphamide versus mycophenolate, you've got higher dose cyclophosphamide versus lower dose, you've got multi-target, and then what are you going to do with the steroids? So these, I'm setting aside new drug development, these have been the major sort of themes of debate. And for example, in terms of black patients, there were arguments from the US that mycophenolate was a much better drug than cyclophosphamide, and then there were arguments originally from South Africa that cyclophosphamide was a much better drug than mycophenolate, and it's all rubbish. I think it's all rubbish, and there are lots of explanations for why these conclusions were reached too. And I think we should use all these drugs, and we should have access to all of these drugs, ideally. So, why do I say this? Well, this was the big 360-patient ALM study that compared mycophenolate head-to-head to cyclophosphamide, and at 6 months showed absolutely no difference. 6 months is a bit early. 6 months is when patients have received 6 months of high-dose steroids. You're not going to see difference in any drug at 6 months if you give everybody high-dose steroids. And that was the fallacy behind the design of this study. But the conclusion is the drugs that equal efficacy. So does it help? Does it not? I'm not sure. What was important is there was absolutely no safety difference. And in every head-to-head study between cyclophosphamide and mycophenolate, there is no safety difference. If anything, there's a trend to more infections with mycophenolate. The only difference is on the ovaries, and that's all about dosing and age. So don't let anyone tell you that cyclophosphamide is a more toxic drug than mycophenolate. The data is that it isn't, apart from the ovaries. So I think we have to treat this with a little bit of suspicion. And what wasn't reported in this study was the 3-year follow-up. Patients were then put on either mycophenolate or azathioprine. And those that had had cyclophosphamide induction had a lower relapse rate. Not significant, but numerically clearly lower than those induced with mycophenolate. And that's not surprising, because most of us think cyclophosphamide has a more prolonged effect after you stop it. So what about cyclophosphamide dosing? So this was the pivotal trial. This was done in Europe by the so-called Lupus group. Compared the NIH dose, which is roughly a gram times 6, to 500 milligrams times 6. And they were looking at essentially progression of renal disease, and they found no difference. And in long-term follow-up, there's an equal number of babies born to mothers in either group. This is just a non-scientific observation, but there were equal numbers of babies. But this was a study done in Northern Europe. This was a study done by rheumatologists, not by nephrologists. What were they dealing with? Was this a relatively benign disease? Maybe they would have done fine on azathioprine. So be careful about non-inferiority studies, is another subtext of this. There's been a recent study from India, not that big, but reasonably well designed, where they did exactly the same comparison, the low dose to the high dose. And they found fewer renal relapses, better extrarenal control with the higher dose of cyclophosphamide, and they didn't find any safety differences. So I'm not sure what to do with my patients. Urolupus is pervasive from the guidelines now, but you would not be criticized, I don't think, by using higher doses of cyclophosphamide, particularly if it's a patient with more aggressive disease or you're worried about adherence, would they come back? Because look at this, fewer renal relapses. That drives end-stage renal disease. So that's another theme. And then we've got multi-target. Multi-target was a concept developed in China, and all of the data until recently is from China and Japan. Multi-target is a slightly grandiose term, because these are not targeted therapies, or not very. And what multi-target means is tacrolimus plus MMF plus steroid. So what we do in transplant. They reduce the doses a bit, so the mycophenolate doses are less than you would give if you were giving the mycophenolate without tacrolimus. And this was a big study, again about 350 patients, convincingly showing that compared to IV cyclophosphamide, you had a faster response with multi-target. They published an open label extension, and the benefits seem to be maintained. So that's the data with the multi-target, and who's using it, I'm not sure. I don't think many people are using it outside China at the moment. But then we have this drug, voclosporin, which is in development at the moment. This is not available, this is a drug in development, but this is a new calcineurin inhibitor. It's an analog of cyclosporin, which has a much more benign safety profile. And they've done the same thing. They've combined it with mycophenolate, 2 different doses, compared it to control, which here was mycophenolate without voclosporin. Big difference. And of course, this is the podocyte. So these are calcineurin inhibitors are protecting the podocyte and getting that early antiproteinuric effect. You're going to see a result of a phase 3 with voclosporin in a couple of months' time. And this may become the first drug licensed for lupus nephritis, which will be quite entertaining because it's quite an old concept using a calcineurin inhibitor. So steroids. So what we've seen with steroids, what I've just put in you here is the 6-month cumulative dose of steroids in various protocols over the last 20 years. And if you stand at the back of the room, you can see there's a trend to using lower doses. And where we're moving towards now is routinely giving IV, 500, 750 milligram pulses, and then starting at 0.5 milligram per kilogram per day. And that seems to be more than enough. And that is significantly reducing the infection rates. And it's the admission to hospital with serious infection that is the main cause of mortality in lupus nephritis. So I think this trend is going to continue. And this is the problem. I just put up here the percentage of patients with a serious adverse event or who have to withdraw due to intolerance. And this is the problem that we face day to day. On average, 20% of people are having a serious adverse event, in other words, admission to hospital, usually an infection. And almost slightly lower, but 15% are having a withdrawal. And to me, this is a bigger problem with our drugs than actually any efficacy failure. So how do you assess response? Well, we look at protein, and we define a complete response as an ACR less than 0.5. Completely arbitrary, but we have some data that if you get down to less than 0.5, you're very unlikely to progress to end-stage renal disease. So that seems reasonable. The problem is different people are going to go down at different speeds. If you start with an ACR of 1, getting down to 0.5 is quite easy. If you start with an ACR of 10, it's going to take you a long time to get there. So how long should you allow your patient before you think of something else is not entirely clear. Red cells, or rather clearance of red cells, has not been shown to have prognostic value in trials. We all do it in the clinic, and we all have a patient whose red cells have gone and then reappear and then they flare. So I'm not saying don't do it, just in the trials they haven't been shown to have prognostic value. We follow serology, and there's good data that if you're hypocomplementemic and your complement normalizes, that's a very good predictor of a subsequent proteinuric response. So the one biomarker to follow, if you can, is complement. Autoantibodies are sort of all over the place, unfortunately, and obviously we all do GFR. The problem with proteinuria is in the patients that don't achieve the ACR of 0.5. So I said if you do achieve the ACR of 0.5, you're probably going to do fine, so we can all relax. But if you don't, what are you going to do? And what's becoming apparent is this discordance between histology and protein. So for example, this study compared to patients having a histological response, in other words, the repeat biopsy, the second biopsy showing no activity, as opposed to proteinuric response. And of those with what was called a partial proteinuric response, in other words, the proteinuria had gone down a bit, but it hadn't got down to 0.5, half of the biopsies showed no activity. In other words, half of the biopsies, the disease had gone, the other half had. And in those with no response at all, the proteinuria hadn't budged, a third of the biopsies had a full histologic remission. So where we're moving towards now is recommending that if you're a partial responder at a year or a non-responder, you do a repeat biopsy. Otherwise, you don't know where you are. And if there's a histologic remission on repeat biopsy, you can carry on slowly backing off your treatment. What are the causes of non-response? Well, adherence, at least in my clinic, is the #1 cause of non-response. We know adherent and non-adherent rates are very high. If you look at hydroxychloroquine as a marker, because most lupus patients should be taking antimalarial, around 70% of people don't take it regularly, just to give you a ballpark figure. Lupus nephritis, we think significant non-adherence rates are around about a third, possibly higher. So that's a problem. There's these patients who present too late, that's a problem. I think far too much has been made about ethnicity and dosing, and I've mentioned this, and the lack of efficacy. Good. So, Rituximab we use. The Rituximab randomized trials failed to show significant benefit, but were not particularly well designed. This is some data from our cohort in Cambridge. So this is all comers with bad lupus, about over half had nephritis, about 147 patients, and overall you see reductions in activity, reductions in steroid dose. But as I was mentioning earlier, the problem with Rituximab is when you stop it. And we either just gave one course of Rituximab, which I think was the red line, or we gave multiple courses of Rituximab over 2 years. And then this time 0 is the time when the Rituximab was stopped. And look what happens. They're all flaring. So even if you just give one course, if you get a lot of courses, it does not have, or does not seem to have a sustained effect. And that's one of the problems with Rituximab. But we use it as a second-line therapy or third-line therapy for lupus nephritis. And if you look at the patients who flared after Rituximab, you're very unlikely to see renal flares. So although over half the patients come with nephritis, interestingly, the kidney actually does quite well. So we like it, but you have to bear these other things in mind. In terms of remission maintenance, I'm not going to show you any data, but I think the most important thing in the follow-up of your patient is the sort of support the patient is given. I really don't think it matters what drug you use within reason. The clinic support, educational programs, the patient taking responsibility for their disease, And you know these patients' lives are often wrecked by their disease, so it's the psychosocial support as well that's so important. We tell the patients they're going to be treated for 3 to 5 years. Mycophenolate or azathioprine or a calcineurin inhibitor. We get the steroids down to 5 milligrams, and if they've been stable for at least a couple of years, we stop the steroids first. And in terms of adjunctive therapy, we try to have them all on an antimalarial, and there is good data. I mean, it's fairly lots of different bits of it, but there's quite good data for the benefit of an antimalarial on the kidney. We routinely use ACE and ARBs, and now in the UK we have this cardiovascular risk assessment called QRISK-3, which actually includes lupus as one of the predictors. So we can actually now do cardiovascular risk assessment on our lupus patients. So that's available to download, the QRISK-3. It's just a little bit like the earlier ones, but a bit more complicated. So before I close, I just want to say a word about new drug development. I touched on voclosporin, which you may hear more about, and about a month ago, Genentech put out a press release because they've been doing a trial with another anti-CD20. This is a drug with a long name beginning with O called obinutuzumab, but essentially it's Rituximab on speed. It's like 100 times more potent than Rituximab, and it's used in non-Hodgkin's lymphoma and CLL. And they reported a positive result in a lupus nephritis trial with obinutuzumab. So we do have now data that B-cell depletion works. We haven't seen the data in detail, but they've issued a press release. So that sort of makes me a little bit more relaxed about using Rituximab. We wait to see the data, but that's another drug that you may need to look out for. And oncology have had this drug for some time. And because oncologists use drugs in such huge doses, it's priced for oncology. And if you're using it for autoimmunity, using much less, that makes the price a bit more accessible. So I'm putting up a whole lot of comments here because often an after-dinner conversation is all about prognostic factors of lupus nephritis. And the reason why I'm putting this up is to make the point there's not a lot that you can do about this, because most of these factors you have no influence on. So there's the demography of the patient, the sex of the patient, the socioeconomic status of the patient. There are genetics that make them more likely to have lupus nephritis, but there are also genetic factors such as APOL1 that confer a worse prognosis. There's histology, you know all about. I said a little bit about some of these things, nothing you can do about, that's what they're coming to you with. There's serology, these are all adverse prognostic factors. I haven't said anything about anti-C1q, but anti-C1q is probably, if they have it, is probably the best predictor of relapse. There's presentation, there's nothing to do about these. And all we can influence is the delay in commencing therapy. And as I've said earlier, which drug you use probably doesn't matter hugely. So that's the sort of big problem. A lot of the prognosis of our lupus nephritis patients is defined before we get to advise them. To summarize, it's not the drug, it's the response that's important. Mycophenolate, big problems with adherence, it's a twice-daily medication. We use regular MPA levels. Now, I'm not sure if you can access MPA levels, but MPA levels, we use them regularly to assess adherence, but also dosing, because the dosing range is 1 gram to 3 grams. And looking at somebody, you don't know whether they're going to be a 1 gram person or a 3 gram person. Calcineurin inhibitor, I've mentioned, we use in class 5. We would use higher proteinuria, I said a bit about multi-target. We use cyclophosphamide for patients we think are going to be poorly adherent, and we use it as a second-line treatment, and we use it if it's concomitant to CNS or cardiac disease, the latter not evidence-based. These recommendations were published a long time ago now, at the same year as KDIGO, the same year as American College of Rheumatology. We are in the process of updating them. I put this up to show some snow before global warming removes it all, but this was in Zurich, and we've written the updated European recommendations, which is a task force of ERA and EULAR, the rheumatology group, and they will be published. They include pediatric patients, and they'll be published in 2020, but also the KDIGO 2020 will include lupus. So I've also stressed the issues with healthcare delivery. management and drug development from very slow. Thanks very much.